by trying to fit every round and triangular peg into a square one, you could achieve desired outcomes.
Right.
And you not only don't achieve desired outcomes, you don't achieve good outcomes.
You forgot the individual.
Yeah, and that is really the individual practitioner and the individual patient. So the medical Stasi, as the Stasis have gone over the years, have been panel discussions with different key opinion leaders from different disciplines, the law, psychosocial, addiction medicine, and straight pain medicine, to try and engage the audience in how to remain unique and clinically focused without getting lost in the apparent rules and regulations that every time something bad occurs, the government comes out and says, well, we never meant that as a rule. We never meant there should be forced tapers. No, we never said that at all, but you did everything but say it.
Right.
And the net result was, by not saying it, the clinicians said it, and we're not fools. We know that the writing is fewer opioids is better, but it isn't always on an individual basis. Better boundaries is almost always better. Better monitoring, almost always better. But this idea that eliminating a molecule is somehow going to create a resonant and sustainable solution, very unlikely. This is a multidimensional problem. And this medical Stasi is really designed to represent different positions from different key opinion leaders on multidimensional problems.
I totally agree with that. I think that when you try to standardize human beings and a relationship involving human beings, and you try to put everybody into the same set of clothing, if you will, you try to turn people into robots with paper, and this is how the boundaries are, they're inflexible, that creates a huge problem. And the practitioner, I think you said this, Doug, that the practitioner in one of the examples shouldn't be reacting out of anger. They need to go back and react and take control of it and explain their rationale and really show their effort to individualize the treatment for the patients. There will be a lot of things that are overlapping and the same between different patients with the same practitioner, but they need to get off that hamster mill and go and treat people as individuals and really insist that that's where our system needs to focus, not on this is the only dose that's going to work for every single patient, these are the only drugs that are going to work for every single patient, naloxone going to work for every single patient. We all know that that's not the case. And yet those are the boundaries that have been standardized to a large degree in the law to enforced through the licensing board guidelines and rules and through expert testimony. It kind of brings it all together. It isn't working. It hasn't worked for many, many years. And it really is, I think we made a good point of saying, go be your individual, go take care of your patients, but remember these things, that you are charged with these duties to evaluate very carefully, and that you don't just do an evaluation through a piece of paper. There's a process involved in that, and that process wiggles all over the place, and you have to dance with the patient. You have to take the individual facts as they develop, not run from them, but address them, reevaluate the risks and benefits, get some of this stuff documented, and continue on, because that's good faith, that's protecting the individual, and it's certainly protecting the relationship.
And it's an iterative process. It's one that may be different tomorrow than it was yesterday.
Right.
And if it isn't, one ought to ask why. One of the things we say about medical necessity in urine drug toxicology is you have to have a reason for doing it. You have to have a result obtained. You have to document that result. And then you have to make a clinical course correction as appropriate, even if that course correction is stay the course, because the evidence you have supports your assessment of clinical stability. It shouldn't be because if you don't do 20,000 urines in that month, your analyzer won't be paid for.
Right, absolutely.
It shouldn't be simply because, well, urine drug testing is therapeutic. There's no evidence of that. In fact, I heard a colleague, a very knowledgeable and well thought of colleagues say, let's be honest, if money were no object, we would test everybody every day. We would do urine drug testing on everybody every day. And I took a deep breath and I said, no, we wouldn't. Because if we did, we would generate so many signals.
Noise.
We would have so much noise, we would never be able to make sense out of it. And worse, do you know how intrusive collecting a urine drug sample is on a person's life? And how medicalized we would make every one of our patients? This isn't just about money. It's about the notion of rehabilitation. It's about the notion of helping people with difficult problems and make better decisions. I almost think in some cases, except for the law notwithstanding, that the opioid is something of a red herring. If you don't get charged at the legal level, you'll get nailed at the greater than 50% preponderance, because it's a civil lawsuit and you didn't maintain your standard of care because you failed to manage risk.